Good evening. Welcome to St George's and welcome to the annual Varma lecture. This lecture recognises and honours the contribution Mrs Varma made to St George's as a senior lecturer in the medical school and a consultant in the trust over a period of many years. And it is a shame that Mrs Varma is unable to attend this year because of a continuing problem with her back, which makes air travel difficult. But I'm delighted that her son, Sunil, is here this evening. We are very fortunate in having two speakers for this year's annual lecture, and it really does, I think, underline the strength that St George's, the university and the trust has in fetal medicine. The title of the lecture this evening, which is a double act, is Fetal Health, Optimal Growth and Placental Function. And the two presenters are internationally recognized for their contribution to fetal health. And what we're going to do is, Aris is going to speak first, and then Basky will follow, and then there'll be an opportunity for questions after the two talks. So let me just first introduce our speakers. Dr Aris Papageorghiou is a consultant and reader in fetal medicine here at St George's. He is Cypriot by background, and but for the fact that there is no medical school, or wasn't a medical school in Cyprus, trained in Sheffield. Of course, now he would have trained in Nicosia and followed the St George's programme in Nicosia, the first medical school in Cyprus. Aris undertook his MD. He saw sense and came to London to do his MD. And his MD was looking at preeclampsia using uterine artery Doppler. And this really started his interest in fetal growth, and he's pursued this ever since. He shares his time between St George's and as a senior research fellow in the Nuffield Department of Obstetric and Gynecology in Oxford. And some of you may have seen a seminal series of papers in the Lancet last month looking at international comparisons of intrauterine growth. And Aris was one of the authors of those papers. Our second speaker is Professor Basky Thilaganathan, who is Professor of Fetal Medicine and Director of Fetal Medicine here at St George's. Basky is a King's College Hospital graduate, and we won't hold that against him either. Spent some of his postgraduate training at King's and then moved to the Barts and London as a lecturer, and indeed I knew Basky at Barts and the London, and I was really miffed when St George's poached him for him to come here as a senior lecturer and to become Director of Fetal Medicine here at St George's. Basky's interests, research interests, are the medical and surgical management of high-risk pregnancies with a particular focus on fetal abnormality and preeclampsia. And I hope you're beginning to see those pieces of the jigsaw bringing together the expertise that we have at St George's in relation to fetal growth and fetal medicine. And I predict that we're in for a treat this evening. So may I invite Aris to give the first lecture for the annual Varma lecture.
Thank you, Professor. I've been told I'm not allowed to cross this line because there's a recording upstairs. Normally I would wander about, but I've been told that I might get put down if I do. So, I'm going to really describe the principal findings from this large study that has been happening. I, as Professor Kopelman says, split my time between here and Oxford, and a lot of you wonder what I do when I'm not here, and hopefully this will explain some of the things that go on. So both of the lectures today are about defining growth and fetal development and how we detect when fetal growth is not normal. And the principal way we screen for fetal growth restriction is by plotting growth on a chart and seeing if the fetus is above within the normal range, if you like, or below the normal range, as in that red cartoon. But if you use a different chart, you can have the very same baby suddenly falling within the normal range. And this is actually a problem that happens in practice because there are a great many charts available that you can use. So in this study here, what they showed is that using 3 different growth charts, you can have fetuses classified as being below the 5th centile at 20 to 24 weeks, anything from 6% to about 24%. Why does this happen? Because different charts are slightly different, and plotting the baby on a different chart will give you a different result. And we see this quite often in our perinatal morbidity and mortality meetings, where neonatologists and obstetricians use different charts, and the same baby ends up on being a completely different percentile. So to start the ball rolling, we had a look at the number of charts that are available in the literature, and as you can see there are many different charts that you can choose for gestational age estimation based on crown-rump length, many different ones on fetal growth and also on birth weight charts. Over 100 charts published on birth weight charts. And this is partly because it's a kind of a nice, easy paper for a registrar to do. You go to your database, you pick up the last 10 years worth of babies that have been born in your unit, and you do a simple regression between birth weight and gestational age at birth, and you can quickly get a large number in your study and get a nice paper in your local journal. The problem with that is that such retrospective studies really limit the amount of information you can get and also the kind of quality control or prospective nature of studies that you can undertake. So if I just give you an example of this fetal growth systematic review, we looked at the literature and there were 83 publications. And what we did for this systematic review was really go through each study and predefine certain quality criteria that we would expect a study to meet, in the same way as you would when you do a systematic review of randomized trials. So for example, how was the design of the study? Was it a prospective or a retrospective study? How was the sample selection? Was it adequately described? Or was there a sample size calculation, for example, in 1.7? And we classified the studies according to high risk of bias or low risk of bias. And we did this for 29 different criteria, and I can tell you that overall the quality of the studies wasn't very good, of the 83 studies, but some of them were a lot better than others. This is just one example. So you're creating a growth chart which relates gestational age to fetal size, and in 5 of the studies, the type of dating, how the pregnancy was originally dated, isn't even stated. So this is really basic characteristics you would expect any good study to be able to tell you how the strategy of dating was undertaken. So these are the top charts that are available in the literature. These are all very well done charts. But look what happens here. You take a baby from that study there with an abdominal circumference of 299 millimeters, and this is worrying because it's a small baby. It's on the 10th percentile. And the treatment you could undertake is very simply to stick it in a plane and fly it from Norway to Canada, and it would suddenly appear to be above the 50th centile. Okay? So this is a very neat treatment for growth restriction. The same is true here. This is a Dutch baby with an abdominal circumference of the 10th centile, so this is a small for gestational age baby, and you fly it elsewhere and suddenly it becomes a 50th percentile baby. And people have said, well, obviously this is because babies in Norway and babies in Canada are completely different, and they are biologically very different babies, and therefore you have these differences. And I think that's difficult to justify when I've just shown you that the methodology of these studies is very, very different in different settings. It's only if you use the same methodology in different settings around the world that you can ascribe something to a biological determinant and not a methodological determinant. Does that make sense? The other thing that these studies do is they are descriptive. What am I trying to say by that? Verburg in 2005 took the whole population of Rotterdam and described how babies grow in that setting over that year. It's a really nice study. It's population-based, beautifully done. But it's describing what happens. It's describing what is. And I think more and more in medicine, what we're doing is prescribing what should be, not describing what is. So, for instance, the diagnosis of diabetes is made when the blood sugar is above a certain level. It doesn't matter how it is distributed in the population. The diagnosis is made on a criterion that is predefined, and that is based on follow-up of people with high blood sugars relating it to an outcome. The same is true for fetal growth. So we need to move from describing what happens to prescribing, saying, how should babies grow under optimal conditions, fetuses and babies? And this is a concept that's well accepted in pediatrics, for example. So some years ago, the WHO undertook the multi-center growth reference study, which built growth curves for children up to the age of 5 around the world. And these are prescriptive standards to assess growth and development in populations of individual children. But those charts start at birth, and we strongly believe that life doesn't start at birth, but starts at conception, and that antenatal events, in utero events, shape the way we grow and develop throughout our lives, and the clock shouldn't start at birth, but much, much earlier. This looks more complicated than it is. These are infant growth standards, okay? The WHO growth standard is the dashed line. So the dashed line goes from a percentage in the population, which is on the y-axis, from -2 to +2 standard deviations. Can you see that? That means that your population should optimally be from -2 to +2 standard deviations, and 0 standard deviations relates to the 50th percentile. That is the prescriptive standard. Look what happens to these populations in real life. In 1985, infants in Southeast Asia, and this is measuring the height of the children, was on that red line, and then it was on the yellow line in 1990, etc., etc. Can you see how the population's descriptive growth is changing over the years and approaching closer and closer to the prescriptive standard? Or in other words, as a population gets healthier, wealthier, and children are better able to achieve their growth potential, they are moving towards a prescriptive standard. And in Europe, those lines are pretty much on that dashed line. In some countries, they've gone beyond the dashed line, and the children are starting to be larger than the optimal, probably. And that's another discussion for another day. So how do we define optimal fetal growth? So the first thing you need to do is define your population as being a healthy population in order to embed your study within that population. So we set out criteria for selection of sites that are going to take part in this study, which meant that the sites had to have a low birth weight rate that wasn't very high. They had to have a normal perinatal mortality rate. And the sites shouldn't be placed on top of a nuclear dump. They shouldn't be on top of a very high mountain, because we know that high altitude, above 1,600 meters, influences fetal growth. So you go around the world, you look for collaborators and people who've taken part in good studies, or people that we've worked before, and you identify your sites. And some of these sites previously took part also in the WHO study that I mentioned previously, the little ones with a red circle around. So going west to east, we've got Seattle, Pelotas in Brazil, Oxford, Turin, Nairobi, Oman, Nagpur in India, and a suburb of Beijing. And these were our study sites. These are not hospitals, these are populations. So in some instances, a hospital is also the population. So in Oxford, for example, there's a population, there's only one hospital, so all the births happen there. But in Seattle, it was 4 hospitals, and in Nagpur, it was 4. In Kenya, in Nairobi, it was a suburb, geographically distinct suburb of Nairobi, which has 3, etc. So having defined your populations, you then define healthy individuals. So these are the 8 sites, and over the study period, there were 60,000 births in that site, and that's our cross-sectional population. Okay, that's the population we're going to start with. So there's all the births that happened in those sites. And these are very useful populations for doing a series of case control studies and population-based studies. Then we'd say, well, what makes a healthy mother? And a healthy mother is defined a priori. She's a non-smoker. She's not very overweight. She has a normal diet. Many, many, many criteria that ensure that the mother has no constraint on fetal growth, including being having no social constraint on growth. And this was different in different countries. So, you know, you want to ensure that mothers aren't very poor, and in some countries that was defined by wage, in some countries it was defined by education, a local standard. It's very interesting when you do this across countries, because we try to define housing, and in England having a thatched roof and no TV is a sign of high socioeconomic status, whereas in Kenya it's the precise opposite. So the maternal inclusion criteria were also there to date the pregnancy accurately, so the mother had to know her LMP, she had to have a regular period, and no hormonal contraception, and an ultrasound was done to confirm this. So these, remember, we had 60,000 pregnancies, about 20,000 women met the criteria of being at low risk, and then from these women we followed up 4,607 women regularly with ultrasound. So women were recruited at 9 weeks and they had scans every 5 weeks throughout pregnancy. And then the baby was measured at birth with anthropometry in detail, followed up at year 1 and year 2. So this is really looking at the first 1,000 days of life from conception to the age of 2. And it's this that I'm going to concentrate on that is going to define our International Fetal Growth Standard. We really went through enormous lengths to ensure optimal quality through training sonographers, standardizing all scans, and having a very detailed process for quality control and audit of data, of images, scoring images, and image review as well. And we had various manuals of operation, which I won't go into now. But this is important. The scans were done every 5 weeks. We had the same ultrasound machine in all the sites, and we measured basic parameters of fetal size. Importantly, when you're an experienced ultrasound specialist, you know that the head circumference at 20 weeks, for example, the biparietal diameter is about 55 millimeters. So in order to avoid bias, we worked with a company to ensure that the images that we took and the measurements that we took were blinded. So the operator couldn't see the measurement on the screen. 3 different measurements were taken, and they were locked inside the machine, and only when all 3 measurements were taken, you pressed the reveal button that you could then use for clinical management. And the data were transferred electronically and automatically to the coordinating site. This is very important and usually done in all spheres of medicine, is to take blinded measurements to avoid bias. Anthropometry was similarly standardized, and all the methodologies in the British Journal of OBGYN, for anyone who's interested in seeing more detail. So I'm going to talk you first through the first analysis. Professor Kopelman was very kind in saying that this was published recently. So the first analysis is really to assess the potential. What is the potential for fetal and newborn growth in these different regions when the mothers, having leveled the playing field, the mothers are all well, have a good nutrition and are well characterized, what is their potential for growth? So then the question is, well, how are you going to compare that? And the way you compare that is using fat-free mass indicators. Why fat-free mass indicators? Well, the first reason is that when you use fat indicators, you can lose and gain weight. So as an example, if you wanted to know the weight distribution in the USA in adults, and you did that study just before Christmas and you did that study just after Christmas, you would get 2 different answers because people put on weight over Christmas. So you need to find an indicator that is resistant to overnutrition and also to undernutrition. And in children, that is height. And in fetuses, it's the skeletal markers of growth. They're also normally distributed, which makes the analysis a lot easier, and they're more precise than fat-related measurements. So first is you decide on your indicator, and then you go and ask your 2 statisticians how you should compare the data, and if you ask 2 statisticians how to compare the data. They will come up with 3 strategies that they can't agree on. So in the end, we said, well, we'll run all 3 strategies. And I won't bore you with the details of the statistics. I've got another 30 slides coming right after this on statistics. No, I don't. One variant component analysis, which examines what proportion of the variability within your data is due to the different sites. So you have all your data, and you can ascribe the variability within your data to a number of factors, one of which is the site. So you can estimate that. Another is a standardized site difference, where you look at the standard deviation compared to all the other sites. And the final is the sensitivity analysis. Sensitivity analysis is the easiest to visualize, so I'll show you the slides on that. So we're going to start by looking at fetal size at less than 14 weeks. This is just to remind you of the countries. And UK, USA, and Italy I've grouped together for this analysis because they're absolutely the same. So I'm going to show you a series of slides. I'm just going to superimpose raw data one on top of the other. So on the y-axis we have the crown-rump length. On the x-axis we have gestational age in weeks. And here the dots, each dot represents an individual woman. So in the UK, USA, and Italy, this is what fetuses are like at that gestation. And if you superimpose China on top of that, India, Kenya, Oman, and Brazil. And I think it's obvious just by visual analysis that those populations are very, very similar. Populations of fetuses are very similar. But obviously you examine that statistically, and these are the regressions of the individual lines. And what you find is that the differences between the countries are minuscule. They're within a few millimeters per day. So that means that you can combine them and create a common growth chart or crown-rump length chart in early pregnancy. And a sensitivity analysis is essentially saying, well, okay, that's the common chart for all babies, but I don't want Kenyan babies to be represented in my population because I have no Kenyans living in my country. And then you can remove them and see what happens to the chart. And if you do that, actually nothing much happens to the chart. So this is what a sensitivity analysis means. You remove one population at a time and see what the effect is on the overall population. And here, if you exclude UK or India or Kenya or China, you can see that there's really no big difference at all in relation to what happens to the underlying chart. I'm going to show you the same for head circumference. This is the head circumference for UK, USA, and Italy. This is China. You remember how it was 5 weeks plus or minus 1 week? Now, if you do that in any country other than China, then people do plus or minus 1 week. But if you do it in China, they do it exactly every 5 weeks to the day. And they are the first to recruit, and they're the best in everything, and they really are. But this caused us a little bit of a statistical problem which we had to fix, which was fixable. This is why you have those little gaps in between. India, Kenya, Oman, and Brazil. Oops. And Brazilians seem a little bit tighter together. That's because the sample size is a little bit smaller. But again, you can see that the head circumference growth all the way from 15 weeks up to 42 weeks is absolutely identical in all the countries. And this is, again, a sensitivity analysis looking at each site and excluding another site. Anthropometry, I won't show you all the slides, just to show you that the sensitivity analysis for newborn length, oh, it's gone, shows no difference. And interestingly, those babies that went on to age 1 and 2, which are shown in red here, were very, very similar to the study from the WHO a few years ago. So the populations are very similar in terms of their growth. This is a variance component analysis I mentioned earlier. So this is looking at the component at the top, which is a crown-rump length, head circumference, and newborn length. And then we look at how much of the variability in the data is due to the different sites. And what you can see is that somewhere between 1.7% and 4.6% of the variation is due to different sites, with all other variation being due to other factors. So this is telling us that a very small proportion only of our variation is due to site differences. So there's not no difference between the sites, but it's actually a very, very small percentage of the overall. And this is similar to the WHO MGRS study, where it was 3.4%, and a very interesting study from 1974 we uncovered during this process, which was also about 3%. So I guess the results of this first analysis is the following. We've really conducted the first study to compare fetal and newborn size in different countries using absolutely the same methodology and the same protocols. And we've done that in healthy populations and healthy women. And we found that a very small percentage only of the total variation is due to between sites. In fact, if we do this analysis, we've got 112 different comparisons. We find only 2 that are statistically significant at the 0.05 level, which is actually less than you'd expect by chance. What these results really show is that the potential for fetal and newborn growth is the same throughout the world as long as you level the playing field. Okay? So of course there are differences around the world in newborn size and in birth weight, etc. But if you had healthy mothers in healthy environments, the potential for growth is the same wherever you come from. And for our purposes, that's the sort of public health message. And from our point of view, it supports pooling the data from the 8 study sites to construct international fetal and newborn standards, which is really the purpose of the next analysis, which was to construct the global curves for optimal fetal and newborn growth. It's very dull showing you a series of equations, so I'm not going to do that, except to say there's a chart showing the recruitment rates, so from 13,000 women to 4,321 women, followed throughout pregnancy with normal, good outcomes of pregnancy, and you can look at charts of head circumference, biparietal diameter, abdominal circumference, femur length, etc. They've been constructed and they're available, and they'll also be made available in all ultrasound machines and systems for assessing fetal growth. And for anyone who's interested, the fetal standards are available in the last 2 weeks ago in the Lancet. This crown-rump length is just in press now in the Ultrasound and Obs and Gynae journal, and the newborn standards also in the same issue of the Lancet above. So what we've done is create these optimal charts, and we hope that they're going to aid us to identify babies that are not meeting their full growth potential. And I'm going to hand over to Basky, because what Basky is going to be talking about is those babies that are normal size but are not meeting their growth potential, although they're of normal size. And just before I go, I'd like to thank all the participants in this very large and very complicated study. Thank you very much. Shall I swap for you?
Oh, yeah, thanks. Thanks, Aris. Thank you, Aris. Thank you, Principal. I was hoping you were going to introduce me and stand next to me so I can show the audience the relative importance of size and how Asians are always smaller than Caucasians, but unfortunately I was robbed of the opportunity. I can't do what Aris has done. Aris has had 3 days a week fancifully drinking coffee in Oxford, planning a study. An opportunity I would love to have had. And to tell you in detail about something that's going to change the way in which we practice. And you really can't underestimate how important having reference standards as opposed to reference ranges are. And these are standards, they're prescriptive, and they're very important. And St. George's is going to be immortalized after Aris Papageorghiou in forever on ultrasound machines because of that work. What I'm going to do is go through a different perspective, is to apply it clinically. Because Aris is an ultimate academic. He loves his numbers, figures, and charts and dots. While he's away, someone has to do the work, and that's me, and Amar, and the rest of the team that are here. Why is it important that we know about birth weight? And why is it important we know about growth? Because of this. However you define
the fact that the baby has not met its optimal growth, there is somewhere between a 2 to 10-fold increase in the mortality of that baby, be it as a stillbirth or be it immediately after birth. And this is a systematic review of some 100+ papers. So one can't argue that if you're not appropriately nourished in utero, you can die. And in fact, you are far more likely to die. Is it only about death? Can we as obstetricians potentially prevent it? Well, we haven't actually conducted very good studies, but there is overwhelming evidence, and especially from our very well-matched colleagues in Scandinavia, who from population data, and this is over 1 million pregnancies, have shown that if one detects growth-restricted babies, and this is moderate, severe, and extreme growth restriction, the mortality risk is almost virtually the same as a normal-sized babies across here. And these are the death rates in babies which were small but not detected before birth. So smallness increases your risk of death, somewhere around 5 to 10-fold. And if obstetricians and midwives can detect small babies, there is pretty good evidence that we're able to interfere or prevent that death. Is it only about death? This is a really neat piece of work from MMI. It was a massive systematic review of some 35 studies looking at neurodevelopmental outcome if you are small. And what he shows is that if you're born below the 10th centile for gestational age, compared to your brothers and sisters above the 10th centile, your developmental quotients at 2 to 18 years of age is on average 30% lower. Okay? Don't misunderstand that for being handicapped or neurodevelopmentally impaired. These are percentage scores in difference at delivery. And whether one can notice that clinically or from the parents is a different question. So where do we go from there? I'm going to define our problems into 2 broad categories: early onset, early on in pregnancy, and late onset towards the end. And there is no doubt in our mind that poor placental function is the cause of early onset fetal growth restriction. So this is a baby that's somewhere in the normal range, whether you use a reference standard or a growth chart, and somewhere along here the placenta doesn't form. There's an insult, and the placenta fails to function. Over several weeks this baby becomes small. And that's a fairly accepted dogma, and I think you will find few people who would argue with that. What is the evidence for that? Well, it's possible. And when I came here, I think I brought only one thing when I came here, which is the use of ultrasound Doppler imaging. That's a technique using ultrasound to look at blood flow, or in fact resistance to blood flow within a vessel. And what I was determined to show was that there are groups of women who have good blood flow to their placentas in early pregnancy, and we presumed they have good and well-formed functional placentas. And there are women with very bad blood flow to the placenta in early pregnancy, which we presume was related to poor or adverse pregnancy outcomes. And thanks to about 10 years worth of work with Prof. Guy Whitley and Judith Cartwright and their team in the lab, and I'm going to summarize it, squeeze it into 2 slides, paper after paper after paper came to show the same things. And this is a really good slide to see. We used to send them samples, placental samples, with high resistance blood flow to the uterus and low resistance blood flow to the uterus. And within a few weeks, they were telling us, on the basis of apoptosis, that means programmed cell death, yes, which blood flow these women had, which is sensational. There's little in biology that actually separates out. Most biological charts you'll see have overlaps, but here you could tell that these cells from high resistance placentas were dying 50% quicker than elsewhere. We also looked at endovascular trophoblast invasion, and if you had very poor blood flows to the uterus in early pregnancy, the placenta had reduced by about 40% poorer endovascular trophoblast invasion. And that means that the placenta wasn't invading the uterus as it should do. No matter what we looked at, whether it was cell-cell interaction, invasion, motility, apoptosis of the placenta, interactions with NK cells, yes, whatever we looked at, there was significant association between the placenta forming poorly in early pregnancy and placental cellular dysfunction. And if you looked at the same measurement, that blood flow within the uterus, and you tried to plot it against a sensitivity analysis for looking at how good is that test in predicting either preeclampsia or fetal growth restriction, which are both markers of poor placental function. Then there is a good relationship between mid-trimester uterine artery blood flows and the occurrence of either preeclampsia or fetal growth restriction. So that's really good evidence that poor blood flows, bad placentas, predisposed to adverse pregnancy outcomes. Where else did we use the Doppler? We used Doppler flows also within the fetus to look at blood flows within various vessels. We could look at it to the placental blood flow, as I've shown. We could look at it in the umbilical artery to see how well the blood was flowing through the umbilical artery, the organ of respiration for the fetus. We could also look at blood flow to the brain. Just like you and I, the fetus, if it holds its breath, yes, and becomes hypoxemic, it preferentially sends blood to its brain to maintain brain oxygen perfusion and shuts off its splanchnic bed. And we could measure that in the fetus directly. We could also look at the ductus venosus, a vessel that you are not familiar with as an adult physician, but is very important. You can talk about it as a right atrial reflection. It tells us how much strain the heart is under. The importance of this is in a seminal piece of work which will be out within a month or two, hopefully in the Lancet, which is a multi-center study, 16 European centers, looking at fetal growth restriction requiring delivery really before 34 weeks. So these are severely growth restricted babies, some 500 of them, with an average birth weight of about 1 kilo, born at an average time of between 30 to 32 weeks, so 2 to 3 months earlier than they should have done. And the key thing here is not surprising. The fact that the determinants of major morbidity are the birth weight, how big you are. Okay, so it seems to confirm everything we know. If we have charts and we look at small babies, we can find out the babies that are likely to die or likely to be handicapped. What is very important here is that the survival rate in this group was greater than 95%, far higher than any retrospective study published so far. And this is a prospective randomized control study looking at either blood flow or computerized CTG in the assessment of when to deliver the babies to minimize mortality and minimize morbidity in this group. I think Aris would agree it's a done deal. I think we've sorted out how we need to do it, and we're not allowed to tell them because it's under, there's a press embargo, so we'll have the answer for you in a couple of weeks' time. And because you're recording, I'll be mea culpa if I say. And this is where everything gets interesting. Late onset fetal growth restriction. Just as you see that curve, later on in the pregnancy, let's for instance say at 34 weeks, you have a baby that's small. And here where the problems arise. Because late onset growth restriction is equally important. If you look at this, these are two different time curves, the early 2000s and the late 2000s. You can see that stillbirth rates increase towards the end of pregnancy, and late onset fetal growth restriction is an important contributor. 52% of stillbirths, dying because you're not growing well, occurs in the last stage of pregnancy. So the end of pregnancy is equally important. Yes, we mustn't assume that just because a woman's got to term, everything's okay. No, half our stillbirths occur at the end of pregnancy. The problems are here. For over 30 years, we've recognized that there is a distinction in how stillbirths occur. And this is, I intentionally chose an old paper just to show you that. If you look at, these are stillbirths plotted on a growth chart or on a fetal weight chart. And if you look at the stillbirths that occur in the preterm gestations, you can see that the clustering is down here. Some 70% of stillbirths in preterm gestations are small or below the 10th centile. Unfortunately for us, at term, it appears to be the opposite. 60 to 70% of stillbirths are normally grown, are of normal size according to our original reference standards. And that's confirmed by our local data here. This is a review of St. George's data for 155 stillbirths over a 15-year period, and you can see that 64% of stillbirths have a birth weight greater than the 10th centile. So these, to all intents and purposes, would appear to be what we would call normally grown babies. Does that risk of death increase as you get smaller? These are birth weight centiles, and you can see that these are clusterings. This is 20th to 80th centile, 80th to 90th centile, etc. And you can see that the risk increases the smaller you are. The problem is that although the risk may increase, the majority of the population are here between the 20th and the 90th centile. And the majority of stillbirths occur in that group. Yes? The same way as we used to assume that because the risk for Down syndrome increased above the age of 35, that's where all the Down syndrome cases were. But actually, paradoxically, most Down syndrome babies are born to women below the age of 35 because the reproductive population are mainly based on the age of 35. Well, what happens when you look at the histology? The histological examination of preterm fetal growth restriction is rife full of those cellular and histological abnormalities that Judith and Guy and all our placental pathologists see. And it appeared until recently that you could see similar malformations at term stillbirths. But actually, there's a problem here. Because when I send my placenta to my pathologist, they insist that I have to write what the problem is on the piece of paper, and thereby introducing bias. Yeah? You won't believe how clever Aris is to have hidden the measurements of ultrasound. So my pathologist is looking for a histological abnormality in the baby that died, and therefore he sees one spiral artery that isn't converted, he'll document it. But he may ignore that in babies that were normal because the baby was normal. So what happens if you take 1,000 placentas at term and you send it to your pathologist completely blinded? And this is done by one of the top pathologists in the country, Neil Sabir at Great Ormond Street. And what they found, remarkably, is that normal histology was present in 72% of normal pregnancies, and normal histology was present more often when the baby had a placental problem at term. Yes? So this is what happens when you ask people to operate in an independent blinded fashion. So at term, it seems to throw the tables completely. Histology is normal in these babies, except for one thing, and this is really important you remember it because I'll come back to this at the end. Hypoperfusion lesions predominate at term. There's hypoperfusions, a villus edema and villus compaction are prevalent at term, and they're not particularly seen in preterm fetal growth restriction. We'll come back to that in a minute. And remember that graph I showed you with the good ROC curve showing that uterine Doppler was particularly good at picking up preterm fetal growth restriction and preeclampsia? When you look at the ROC curve for the prediction of term onset of either preeclampsia or fetal growth restriction, 0. My 10p toss of a coin is better at picking up term fetal growth restriction. And this is Aris's work. This is from his MD era. You can see that as you progressively go towards term, the chances of predicting problems in a pregnancy are low when you use Doppler in the mid-trimester. So how does this add up? We have a real problem at term. Yes? And I'm going to pick on a clinician. Edwin, you're sitting there. This is a growth chart. Let's pretend it's Aris's growth chart, because even Aris's growth chart has a variation within it. Yes? It has a 50th centile, a 5th centile. So it's a growth standard that Aris. So we take the chart out of the Lancet, and you are in clinic, because you're a clinician. Yes? You're sitting there, and you have 2 women in 2 rooms. 1 woman in each room. And you have this woman here who has a chart and this red spot, like dangerous red spot there, or the nice green one there. Which one are you going to go for? Which one are you more dangerous, concerned about?
The green one.
Why?
Because the baby is big and the placenta is not enough to give.
How do you know? It's green. It's nice and green. You know, it's for go home, come back next week, come back 2 weeks to see your midwife. Come on.
Because it's late placental failure. Those are the...
Fantastic. So how is size going to help us? Yes? Yeah. Edwin is an educated obstetrician. Rare entity nowadays, you might say. Okay? But the convention would dictate that in 99.9% of other UK establishments, the woman with the red baby is going to be, you know, channeled, admitted, monitored, induced, cesarean section, whatever you may. And the woman whose baby is on the normal range would be sent home saying, all's good, love, you know, just come back in a couple of weeks for a midwife visit. Okay? This is the issue about prescription. Where is it that you should be? Yes? If this baby was meant to be here and it's here, then actually it's almost achieving its optimal growth. Whereas if this baby was meant to be on the 80th centile and is on the 20th centile, then that baby is being very underfed. The problem is we don't know where it should be. We just know where it is. And even Aris's charts have a range. And they don't tell us where that particular baby should be. They just say where the population should be. So, what are we going to use? Fetal size? Now, we've already agreed that the majority of stillbirths are of normal size. So let's use fetal growth. Yes? So you take a chart, you plot the baby every few weeks like you do in China every 5 weeks. The problem is that without Bill and Melinda Gates supporting me to buy the machines, to pay the people to scan them every 5 weeks, it ain't going to happen. All right? So we're never going to see that growth, yes, unless we institute a policy of serial scanning to assess the fall off in growth velocity, number one. Number two, the complexities of deciding how many centiles you need to cross and how that's related to mortality so that we can intervene are even more complicated than the 3 statistical analytical methods that Aris used to do the chart. So we wouldn't know where in this crossing the centiles we would do. So is it better that we look at placental failure? And placental failure is fairly easy. As you become hypoxemic, I told you before, you send blood to the important parts, your brain, adrenals, and heart, and you cut it away from organs that are not so important to you. And as it gets worse, yes, you have central nervous cellular dysfunction, and only then does the baby start doing things like stop moving, yes, not do breathing movements in utero, and start to change its biophysical profile, something that you might recognize on scan or the mother might recognize. So it's actually very severe function, but this arterial redistribution can be measured as we did in the preterm group. The problem is that when we look at this redistribution to the brain compared to the rest of the body, this is what you should see. This is the umbilical artery to the placenta, and you see there's a high resistance. The placenta's not working well. It's a bit cloggy. It's like a rusty radiator. It's not working well. And the middle cerebral artery has dropped its resistance. It's vasodilated to allow oxygen and blood flow to its brain. And that's what we see in preterm fetal growth restriction. But paper after paper has said that this ratio between high resistance here and vasodilation in the brain is related to adverse outcome in preterm, but it seems not to be related to adverse outcome in term. And we kind of accepted it for many years until we had a seminal moment where you think, well, if you're a preterm fetus and you become hypoxemic, you dilate your vessels in your brain. And if I get all of you in the audience to hold your breath, you'll vasodilate your vessels to the brain. So why is it that when you get to 34, 35 weeks, you stop doing what is innately part of human nature? It can't be right. So this is the next few slides, a series of work that Asma Khalil, who's one of our younger colleagues, has been pioneering, which is we took 10,000 CPR, and CPR is a measure of vasodilation. We took 10,000 measurements we've done here over the last few years, and we plotted them on a birth weight centile, and this is important to follow. We plotted all the babies between the 10th and 90th centile and looked at their variation in their CPR. And their CPR is an index of redistribution. If indeed babies on the 11th centile are just the same as babies on the 89th centile, yes, if Peter and I are equally well nourished, then our indices on a blood test should be the same, should they not, Peter? Excellent. What we couldn't understand when we plotted this was why babies on the 75th to 90th centile had better redistribution or no redistribution at all, and as we got smaller within the normal range profile, these babies seem to have lower and lower CPR indices, indicating that these babies were more likely to be redistributing despite being the normal size. So if you draw a line across here and say, okay, we take our 75th, this group to be optimally nourished, which is reflected in population studies in adult life, then what you see is progressively, as you get smaller, you have more and more babies which have a suboptimal CPR. And we created this chart to show that as you get into the lower centile groups, the percentage of babies that have a CPR indicating fetal hypoxemia increases progressively. So the reason we failed to see this before is that the charts on which we measured our CPR, the charts on which we measured blood flow to the brain and the placenta, were descriptive charts in the same way that Aris has shown for fetal growth weight standards. We took babies and showed what they were. We didn't show what they should be. And within this population that were used to measure our blood flow charts, were babies that were hypoxemic already. And their hypoxemia was hidden because we assumed they were normal. And very easily, if you measure CPR using our optimal CPR standard, we find some very interesting things. This is CPR and the low pH in labor and the need for emergency cesarean section or for a forceps or von Tu's delivery. What we find when you do logistic regression analysis is that birth weight does not influence the probability of the baby needing either a cesarean or a von Tu's or a forceps for a low pH, but CPR mom does. So the CPR influences it, but not birth weight. If you look at CPR and neonatal morbidity as comprised of admission to NICU, respiratory distress, sepsis, neck, bronchopulmonary dysphagia, etc., again, birth weight centile does not influence it, but CPR influences neonatal morbidity. And finally, if you look at mortality, the likelihood of death, yes, whatever the CPR is, and you can use it against uterine Doppler and birth weight, CPR, once you adjust for other variables, is significantly correlated with either stillbirth or perinatal mortality, but not birth weight and not uterine artery PI at term. If you look at other published data, and this is published data that was largely ignored because no one could understand why normal CPRs should be create problems, but these were papers showing that apparently normal-sized babies were more likely to have neurobehavioral problems if their CPR ratio, if they were redistributing before birth, long-term neurodevelopmental outcome. So here is our problem we've had. The problem we've had is that obstetricians, we defined size as a disease, not placental failure. In order for us to be growth restricted, we must have failed to have got to the 10th centile. When in reality, what we should have done is done what Peter's done, which is say malnourishment is the disease. You may or may not have growth problems as a consequence of that. So when a baby has early placental failure, the insult is early on in pregnancy. The baby has low metabolic demands, and that placenta that is failing can still continue to feed that small 500-gram baby and keep it creeping along. And there is a long latency between the onset of placental failure and the demise of that baby. And in that latency period, the baby can become small. The difference with late placental failure is that the baby has already got to 3 kilograms at 39 weeks, at 8.5 months. And if you're 3 kilograms, you can't suddenly shrink. And if your placenta fails at 39 weeks, when you have high metabolic demands, 5 times as much as a 500-gram baby, and that placenta fails to deliver to you, then the latency between the onset of placental failure and demise is extremely short. And you don't have time to become small. So fetal growth restriction is hardly a cardinal feature. And the problem we had was this. Naming the disorder of fetal growth restriction has hampered really the research in this field. Fetuses may be compromised by poor placentation, typically in early growth restriction, or by unmet metabolic demands in late growth restriction. And we need to focus on assessing placental function or well-being rather than fetal size as the cardinal feature that determines both mortality and morbidity. I'm going to stop there, but I need to show 3 more slides because the $64,000 question is, okay, we understand early fetal growth restriction because the placenta didn't form properly. What in the world is going on in late placental growth restriction, as we used to call it, or placental failure? Because it clearly isn't a primary placental implantation problem. And this is where I really have to do, is that we become focused with the obstetricians at just looking at the placenta. And our understanding of maternal cardiac performance is that the mother has a heart and she pumps the placenta and she's well, she goes home. And we really haven't delved into that in great detail. And I'm really not doing this a service because rather like Judith and Guy, I'm going to show you just 3 slides to encompass something like 6 years' work in maternal cardiac function done together with George Sutherland, then Sanjay and Raj Sharma. And, you know, to their credit, both the Sharmas have pumped out 2 papers in circulation just in the last 2 months on this work. We've concentrated on the placenta and the placental histological problems. But a comprehensive study of 600 women, again, prescriptive. We took the healthiest women. They were normal size, didn't smoke, healthy, no comorbidity. So very much like the work that Aris has done, we said these are the optimal, ideally healthy population. And we did a huge amount of work to follow them up throughout pregnancy and for over a year later. And you need to understand that we can describe the heart according to how muscly it gets remodeled on the basis of how it works, how much the heart muscle gets impaired, and then finally how much the diastolic and systolic, the chamber function, is compromised by the pregnancy. And it is amazing to us that although most of the things were okay, if you look at this chart, you'll find that during pregnancy, first and second trimesters are okay, and the third trimester is seemingly okay. But when you get to term, in these normal 600 women, 30% of term women have impaired myocardial relaxation, and 20% of them have overt diastolic chamber dysfunction, according to the American Heart Association criteria. Okay? So normal pregnant women have significant cardiac compromise at term. Rather shocking when we found out, but actually we shouldn't be shocked. Because a woman in pregnancy remodels her heart and thickens the muscle by 50% in 6 months. The same as our British cycling athletes take 2 years to achieve. Okay, but she's sitting in an armchair eating crisps. Maybe the British Cycling Association need to look into this some more. Okay? And it's incongruous because I don't know about you, but I fell asleep in those lectures where they said mother's heart, high cardiac output, mother's hearts are really performing well, they're doing really well, hyperdynamic, they're all okay. We said, well, how does that fit in? How can this failing heart have high cardiac output? And this is where we come to Peter's expertise, which is about a huge issue about cardiac output isn't an index. Cardiac output, what is normal for you, depends on your metabolic demands. And therefore, a mother who raises her weight in pregnancy, who raises a hugely metabolically active fetus in pregnancy, is making huge demands on the fetus. And if you correct for the fact that her demands are increasing, what you find is that the cardiac index in pregnancy actually falls. It stays absolutely static from non-pregnant controls throughout pregnancy, but it falls, and in compensation, her total vascular resistance index increases. What this tells us is that about 20 to 30% of women at the end of pregnancy are undergoing pump failure, and they're having to make quite dramatic changes to their vascular resistance in order to focus the blood that they're failing heart to the brain and to the fetus. And that, ladies and gentlemen, is a fundamentally amazing concept. Thank you.